One last question that's relevant here is about where testing should be done. And this may be different in the United States than it might be, let's say, in Europe. And so I'd like to ask Alan, this sort of molecular testing that we're talking about, should it be central laboratories? Should it be only in academic centers? Can it be in community hospitals? What's your thought here?
Yes. So I think that the important point is actually what you're of course you're getting at with the question is the validity of the test results. And not being a pathologist and understanding necessarily the reproducibility of all these testing, I think the important point is that it be done at an institution, wherever it be, that they're very comfortable, they're CLIA certified, and they're very comfortable with the reproducibility of their results. And in some cases, that may well include community centers, academic centers, or central laboratories are all viable candidates for that. But I think that the medical oncologist, wherever they may be, needs to understand the strengths and limitations of their laboratory. My guess is as we continue to move forward and more of these tests come forward, there will be less of a need perhaps for reference laboratories and more that they will be done potentially at larger community centers. There certainly will always be some centers that will have to send out somewhere, but I think that's the key component is the validity of the test.
Are there other thoughts on this?
I think we're probably a few years away from community centers truly being comfortable doing this and really having the resources to do this. EGFR, perhaps ALK, as time goes on, there'll be a greater comfort level. But in the community, I would say, almost with that exception, it is generally sent out. And there, of course, there are several central laboratories that are able to do this and frequently do it quite expeditiously, which is really the other key issue. It doesn't help if we have incredibly accurate results, but we're waiting 3, 4, or 5 weeks. We need incredibly accurate results within a week or two, and there are some commercial entities that are able to accomplish this. It's a much different issue in academia, particularly when there are additional resources that are available to conduct these tests. And what I've found for the most part is there's some sort of partnership going on between both the academic institution and some of the central labs in terms of testing. But I think for a community-based oncologist, they should be aware that there are several commercial entities that can do this, and sometimes the impetus has to come from them. It will not come from the pathologist. So a continuing dialogue between the community oncologist and their local pathologist is absolutely essential.
I agree. I think the key point, though, is what Alan said, and that's that some of these tests can be quite difficult. Fish testing for ALK is not a chip shop. It requires a fair amount of expertise. Now, having said that, I think we also have to acknowledge that this is also a process in evolution. It may be in a year or two from now that we will be accepting IHC testing for fish. I think we have to admit that that's going to change over time. But I think the important thing is that physicians have to be comfortable where they're sending this, that they're sure that there's a level of expertise and they're getting accurate information, because these are not easy things to do.
And I would just talk a little bit about the international component. I mean, we have a lot of colleagues that often contact us about these new molecular testing. And a lot of countries are actually centralizing their testing, which is different than here in the United States. And that actually may be wise for that particular area or region, such as Central and Latin America.
I think the example of the ALK fusion is particularly cogent here because, as Mark said, although pathologists in community hospitals are very comfortable with doing a FISH test for HER2, for example, for breast cancer, the break-apart FISH test for ALK is much more difficult. And to me, at least, you want a laboratory that's doing this in relatively large volumes, and they're doing it all the time. But I think also, as Mark said, my impression is if we had this conference 2 years from now, we probably will be doing a screening with immunohistochemistry and then confirming it with FISH. I can tell you that in some areas of the world, like Japan, there is no FISH testing. All their ALK positivity is by IHC. And of course, even for EGFR mutation, there are antibodies now that are mutation specific. So even for that test, we may in the future move to IHC with some sort of confirmation. Agreement?
Yes.
Good point.